This is a case of a 58-year-old female who actually presented to the hospital with headaches. She described them as intermittent in nature, kind of over the last 5 days, associated with nausea. She didn't have any kind of alarming features, such as blurry vision, chest pain, or shortness of breath. Um, she wasn't able to give much more of a detailed history regarding these headaches. She did say, however, that she was not compliant with her medications as an outpatient. Her past medical history, she had a stroke 3 years ago with right-sided residual weakness, also with a history of CKD, baseline creatinine around 5.0, hypertension, and diabetes. Social history, she used to smoke crack cocaine, but currently says she does not use any, crack or any other substances. Former cigarette smoker as well. She lives with her daughter, who provides her assistance. Given her stroke, she is, on disability and not currently working. No prior surgical history. This is a list of her home medications. She's on a baby aspirin daily, Lipitor 40 milligrams, Carvedilol 12.5 BID, amlodipine 10 milligrams daily, torsemide 40 milligrams daily, as well as insulin for control of her diabetes. But again, she did mention she was not taking these on a regular basis. So this is the physical exam when she presented to the hospital. Notable for severely elevated blood pressure, 240 over 110. Heart rate was normal. She was sitting well on room air. In no acute distress. She was fully oriented, but there was some mention of some kind of memory issues, kind of short-term memory loss. Otherwise, her, cardiac exam was unremarkable, normal pulmonary exam as well. She was noted to be slurring her speech in the field by EMS, and they did note that she had a little bit of, weakness in her right upper and lower extremities with some increased tone. And therefore, a stroke alert was called due to these findings. Neurology saw her as soon as she came to the hospital. They noted that these were her baseline neuro findings. She was taken emergently for a CT head, didn't show any acute abnormality, but did show an old infarct in keeping with her right-sided weakness. So these are her labs on arrival to Cooper. Her creatinine is 5.0, which is around baseline. Hemoglobin of 8.8, baseline is around 8 to 9. Her lipids are shown there on the right. Troponin was checked as well. It was elevated but flat in the setting of CKD. Here's her EKG. This looks similar to all of her other EKGs in our system.
A major acute concern here?
Yeah, it's a sinus rhythm, which is important in the setting of stroke. Okay. And there's, poor enteroceptal R wave progression, but there is a little R wave in V2. There's a non-specific ST abnormality. If it looks like our old ECGs, I'm less impressed, so I mean, there are T wave abnormalities that are there, but again, that may be part of her older, EKG history. I'm not sure. So nothing that's screaming out here. However, it's an abnormal ECG.
Would you be worried that this might represent ischemic heart disease, or do you think this is pretty classic for repolarization abnormalities due to LVH?
It looks asymmetric. For example, in V6, the T-wave inversion in V5 is asymmetric, favors repolarization from LVH. Interestingly, she doesn't have the voltage criteria for LVH. So I definitely want to see an old one. So it could go either way, but right now it favors a repolarization abnormality by the appearance.
She did not have a chest X-ray on admission, so I have not shown one. And so therefore, given her elevated blood pressure, she was actually given a dose of IV hydralazine in the ER, and her blood pressure went down to 130 pretty quickly. So that was, obviously stopped. She was admitted to medical telemetry for treatment of hypertensive urgency, and ultimately they restarted her home medications, and her blood pressure improved within 36 hours or so. Her symptoms that she initially came in with, the headaches, did resolve with improved control of her blood pressure. So her creatinine, however, continued to trend up during the course of the hospitalization. Initially when she came in, it was 5.0, went to 5.2, 5.5, 5.6. So nephrology saw the patient and recommended that she be, seen by vascular surgery for long-term HD access. Vascular saw her and recommended that cardiology be on board for risk stratification. for this procedure. So she had actually previously been seen by cardiology in December of last year for the same reason. At that time, the recommendation had been for an outpatient pharmacologic nuclear stress test, but she had been lost to follow-up, and it had never been done. And so, when we saw her on consult, we did kind of ask her the usual things that we talk about when we see someone for risk stratification. She denied any angina, no dyspnea on exertion, no other symptoms of overt decompensated heart failure. Regarding her functional status, she, because of her stroke 3 years ago, was really able to do very minimal amounts of activity. She could walk, but really struggled going up the stairs, was unable to do light duties around the house. And so, in keeping with the recommendation from the prior consultation, but also given her limited functional status, we recommended the same as had been recommended back in December.
So the point of presenting this case today is to review what we do when we're asked to see patients for evaluation and quote unquote clearance for non-cardiac surgery. And this was a good example. I'm told the consult service sees a ton of these every week. And we also obviously see a ton of these in the outpatient department every week. This is a little different because she's actually in the hospital, but she's a 58-year-old woman, just to summarize, 58-year-old woman with significant chronic medical illnesses. She has stage 5 CKD, she has type 2 diabetes, she has severe hypertension, she's had a left hemisphere stroke with right hemiparesis, and in addition, she's been non-adherent with her medical therapies. Let me start with Dr. Mazzarelli. What would your approach be? She does not have heart failure. She does not complain of angina. Her functional capacity is relatively limited, and the surgery that she's anticipated to have is creation of dialysis access.
Yeah, I mean, she's high based on her comorbid conditions. If there's various risk stratification calculators that you can use, but she typically would be considered high risk based on her comorbid conditions. Her lack of activity makes it really hard to know if she truly, if she's having angina, or she's having some other type of symptom, because she doesn't exert herself. So this would be the classic patient that would be characterized as achieving less than 4 METs, and given all the other risks, some type of additional imaging testing would be indicated to better risk stratify her, or to better prepare the surgeons and anesthesiology for what could happen peri, or postoperatively. So it would not be unreasonable to do some type of imaging, typically nuclear stress test, and obviously echo if you thought you heard something on exam to suggest a significant valvular abnormality. It's also not unreasonable to assume that this person could have LV systolic failure from chronic hypertension that's not, well treated, and so on and so forth. So she'd be high risk.
Let me just play devil's advocate for a little bit. She's a woman who has no symptoms. Would you consider this vascular surgery high risk, or would you consider it sort of moderate risk surgery, creation of the dialysis access?
The AV fistula?
Yeah.
It's not a high risk vascular surgery, like carotids or other, like abdominal aortopathies and things like that, but it's still a vascular surgery. So, I mean, it's concerning, but typically, yeah, it's not as much of a physiological strain as some of the other vascular surgeries. But the patient herself has so many risk factors.
Yeah.
And I don't know how you'd possibly be able to assess whether or not she has symptomatic cardiac symptoms.
Right. Again, just to play devil's advocate, a lot of the cardiology societies are trying to dissuade us from doing preoperative testing on a lot of these patients. Would it make a difference? If you did a stress test and you found ischemia, she's relatively asymptomatic. She's likely would be high risk for revascularization procedures, especially since she's demonstrated pretty significant medication non-adherence. So does that play into your decision as to whether or not to do additional testing?
Can I just add, just as a disclaimer, there's that whole separate caveat that, correct, like you really shouldn't be aggressively pursuing revascularization in a patient if you wouldn't have done it otherwise. So, I do think it is helpful, again, stressing the point that when you see someone preoperatively, you're really just doing testing because you're providing information to the other physicians who will be taking care of them, not necessarily because you plan to revascularize. So if that makes any sense, I think that's maybe what you're getting at. So let's assume that her entire anterior wall was out. Well, if you happen to pick that up as an outpatient because she was having some vague symptoms, you might actually be worried. It's a huge amount of territory involved, so on and so forth. But someone could have apical ischemia on a nuclear stress test pre-op, and you would then be able to say, look, I think this patient's a little higher risk. They may have CAD. We're not recommending that you cath them because it's 5% of the myocardium, but I do think that having additional information about how the heart's functioning is helpful to the other physicians taking care or other people taking care of the patient.
Yeah, I think that's a great point. You don't necessarily have to act, but it does provide prognostic information that is useful when you're taking care of her or patients like her. So, Dr. Weisstock, I know you have the talk prepared, but without giving away your talk, how would you approach this patient? Anything to add to what Dr. Mazzarelli said?
No. I think Dr. Mazzarelli really touched on all the key points. Let me just underscore, you never want the treatment to be worse than the disease. So, if somebody's coming in for an AV fistula, you don't necessarily want to do bypass surgery to get them through that. So you always have to keep a level head as to what your decision making is, but nonetheless to notify the team that's going to be operating about her level of risk is very useful as far as low, medium, or high. And we'll talk more about that.
Can I add something, which is we are unusually blind here in terms of our usual evaluation because she doesn't move about, so we don't have the lack of exertion and the fact that she's a diabetic. So a non-diabetic patient who exerts themselves gives us a lot more data than we have on this patient.
And just to reemphasize what Dr. Mazzarelli said, she's got pretty much all of the high-risk features if you're looking as to whether or not to evaluate for CAD. Prior stroke, bad kidney disease, type 2 diabetes, probably hypertensive heart disease. She's got a lot of comorbidities that make any non-cardiac surgery more risky.
Just to make one point, Rick, is that if you go down the road of pharmacologic nuclear testing, which is reasonable, at least from what we're told, then you follow the goal-directed medical therapy. So if the stress test is markedly abnormal and you would ordinarily cath that person, then you go down that road. And if that leads to triple vessel disease or left main disease, and you'd offer surgery to a diabetic with that condition, then that's the kind of the clinical guidelines. So you still follow the clinical guidelines for whatever the disease is. The question is, do you start with the stress test or not? We'll talk about that.
Okay.
But if once you do it, then you have to follow through on all the other guidelines.
So we did pursue the stress test. Here are the results. So there were no kind of gross abnormalities on perfusion, but I will clue you into the TID here of 1.35.
So we don't have all the images, but so for those who are not used to looking at these, we're looking at the perfusion. On the middle is the stress, right? And the one below that is the rest. We don't have to look at the gated stress on the top line. And we're only seeing about 5 or 6 representative images. And there's a little hint that maybe in the anterolateral area in the mid-ventricle, maybe like between 1 o'clock and 3 o'clock here and here. Yeah, it looks a little less than on the resting images where it's much hotter. And that's probably what corresponds to this defect or on the stress on the bullseye plot here. So these images do call a small area of mild ischemia, and this says lateral, but this may be a mild, at least to my eye, mild anterolateral ischemia. And then you also have this TID ratio of 1.35, which is not normal. Obviously, TID should be less than 1.2, 1.22 for pharmacologic stress. So our interpretation may be a little bit different from what the official interpretation is.
So in fact, the report was that it was a normal study without any evidence of stress-induced ischemia. The EF on this study was estimated to be about 60%.
So Dr. Mazzarelli, we'll go back to you. I don't know if you want to go back one, Raj. I don't know if you think it's more normal than not, or if there's mild ischemia, but how does this affect what you're going to recommend?
This is tough. I mean, the concern would be so there is TID with no perfusion abnormality, which makes you feel a little more comfortable. But when you have TID with, even this is really a small amount of myocardium, right? The SDS score, I think, is 1. It says there, right?
Correct. Yeah.
But this is really not a very pleasant result to get because, this person very easily could have balanced ischemia. It could have 3 vessel disease, left main. I still would take a step back and look at I think one of the key points in this patient is that she is not medically managed based on the presentation. And this, I may say to the surgeon, look, this is technically not a normal study. I'm not entirely sure what to tell you, but maybe we could wait. Maybe we can get her on good medical therapy, see how she feels, and then revisit if this is not an urgent. But I would also be hesitant to take someone to the cath lab. I mean, I don't know. It's tough, but she would technically, based on this finding, she was high risk to begin with, but I would be worried that there could be during induction or during anesthesia, there could be some issues because she might actually have significant CAD. Pretest probability without imaging is highly suggestive of CAD.
Sure.
So, but she's not medically managed well. So at least we have that to fall back on.
Mm-hmm. And again, as Dr. Weinstock mentioned, you want to sort of evaluate and treat these patients as you would whether or not they were having an operation. And according to the most recent trials, including ischemia, this is a stable patient. Now we know she's quote unquote stable, although her blood pressure is way up. So patients with coronary disease who are clinically stable should do just as well with medical therapy as with revascularization. Take that with a grain of salt, of course, and you apply it to your individual patients. But is there anybody out there in the audience who wants to make a case that we should now proceed with coronary angiography? Dr. Ilianis, you want to catheter?
I would be glad to accept the RVUs, but we don't need a catheter patient.
Why would you? TID, a mild perfusion abnormality, multiple risk factors, non-ambulatory, basically, so you can't rely on symptoms.
I still would go back to the clinical question: is this patient going to tolerate a superficial vascular surgery, which is a shunt placement? That she's not medically managed. I think by appropriate use criteria, she would not be someone I would charge to the cath lab despite having a mild perfusion abnormality and a TID. All the recommendations from the guidelines suggest she should get medical therapy first and demonstrate some other objective evidence of ischemia. Unfortunately, she can't walk, so or give us a functional assessment. Otherwise, that would be chimed in as well. So I think at this point, though that my chosen career, I think this is not the time for it.
Anybody, uninvasive cardiologists want to twist Dr. Ilianis' arm to cath, or I'm not hearing great enthusiasm for that? Okay.
I just wanted to add, and I would not cath this patient, but I just wanted to add, if you did cath her and you found the data that you feared, which is significant CAD, what are you going to, this patient's not likely to be a surgical candidate. Are you going to do a single vessel PCI, which leads to incomplete revascularization, which doesn't really help her cause for preoperative, assessment? You know what I mean? So it's like the data that you obtain is also really problematic. So.
Joanne, to your point, and I brought it up briefly, the appropriate use criteria. I mean, I really think this lady's unmedically managed. They brought that forward to stop us from PCIing people who are not medically managed to come with mild perfusion abnormality. Even by perfusion abnormality, she's somebody that should not be intervened to or catheter. It's described for mild perfusion defects. The TID is actually not brought into it.
It's worth pointing out that people have been this is not unusual, and that people have been struggling with what to do with patients like this for 40 years. I'm sure I don't want to step on Perry's talk, but this still remains as we've been hearing this morning, a not straightforward medical decision sometimes.
Mhm. There was I think there was a high-risk nuclear subset in the ischemia trial, if I'm not mistaken, that also did very well with medical therapy. Something that I didn't look up prior to this meeting, but I think was published as a subset of the ischemia trial. Okay.
So given the TID and the obviously possibility of balanced ischemia, we did pursue coronary angiography.
Leo was right in the room here. I think we have pretty good images. Do you want to comment?
This is the RO projection of the right coronary artery. Lines on the left.
Yeah, actually, we have obviously our new fellow, so
yeah,
you have to be more detailed in your description. That's great. Thank you.
No.
Yeah.
Proximal RCA seen. There's some mild diffuse plaque, approximately mild, I would say less than 50. The distal right coronary artery proceeds down. The PDA is the one that goes from left to right all the way to the apex of the heart. It has mild diffuse disease in it. So nothing striking in this angio. Here's a kind of an AP view of catheter tip, groin access, left main looks angiographic stuff out. Left main looks clear. The LED goes to the apex, goes up and down. It's more of an AP view. The circumflex is obscured by the LED, but actually, fairly unremarkable. I'm surprised actually, given risk factors and functional status under PAD, just peripheral vascular by stroke, and therefore I would expect her to have some coronary disease. But nice wraparound LED type 3 with some maybe mild diagonal disease. So the LED comes up straight down. The diagonals come off of the diag, off of the LED, and then the angle. So non-obstructive coronary disease, I would say.
Yeah, can you go back to that? So, I mean, a couple of points. One is you can't really see the proximal left coronary. This was not a great choice of a view, but basically what you do see is there's diffuse disease there. So even though you don't see a focal 80% stenosis, if you ever have the misfortune of looking at an autopsy on a patient like this, you'll find that the inside of that coronary, especially from the mid-LAD down and also the whole distal right, is caked in plaque. So it's diffuse disease, typical of a diabetic. The other interesting observation here, we do most of our CATs from the radial, and presumably that femoral in a diabetic is always a higher risk. But on the other hand, this is a patient who's going to have dialysis, and I'm sure they went from the femoral because they wanted to preserve the radial arteries.
Actually, you got a sense of that mid-LAD. There's almost, I mean, maybe it's a bad picture, but it's almost bridging. But yeah, there you constrict during systole constricts a little bit, which is unusual. But again, your point is well taken. No stents here, Joanne. Sorry.
Good for her. I'm assuming there's a twist.
So this is a report. Prox RCA, as Dr. Iliadis mentioned, is 40% stenosis, a little bit of disease in the distal RCA, and there wasn't any significant CAD that was noted for the report. So she was monitored in the hospital for CIN post-procedurally. Obviously, she's very high risk with CKD stage 5. She was ultimately discharged, and she'll follow up with a vascular surgery for outpatient fistula placement. There were no changes made to her medications on discharge. It was just recommended that she, continue and actually take them. Yes.